Welcome to the Mental Health Book Club podcast with your hosts, Sydney Timmins and the Secret Psychiatrist. We would like to take this opportunity to let you know that we will be covering a diverse range of mental health topics that may be distressing to some listeners. You can find a full list of the topics being covered in our show notes. Please check the show notes before listening to any of our episodes. Welcome to the Mental Health Book Club podcast with your hosts, Sydney Timmins and the Secret Psychiatrist. And just in case you haven't listened to the podcast before, I'm going to get the Secret Psych to just give us a little bit of background about herself.
Hello, thank you for the introduction. I'm the Secret Psychiatrist. I'm a female psychiatrist currently in London working in the NHS. And you can find me on my website, www.thesecretpsychiatrist.com, Twitter, Facebook, Instagram, and also on this podcast.
Yay! All I can say is, yes, we have you.
Party popper.
Exactly. What I need now is some fireworks sound effects or something, because that would be awesome.
Oh my gosh, that would be great. Or champagne bottle flying.
Yeah. But anyway, so today's episode, I was hoping that we could speak to you about postpartum issues associated with mental health. So we've just recently read Diane's book, which was Birth of a New Brain, where she ends up kind of triggering off her postpartum bipolar disorder. And I know that there are other disorders out there, so I was wondering if you could tell us a bit more about them.
Yeah, brilliant. So I mean, again, not many people know there's a whole different specialty called perinatal psychiatry. So people just think psychiatry, but actually it's split in loads of different umbrellas. So you've got forensic psychiatry, you've got old age, you've got liaison, you've got child and adolescent, you've got general adult, and you've got perinatal psychiatry and psychotherapy. I mean, it goes on and on. So perinatal is a whole different subspecialty and something that doesn't have enough light shed on it, actually. And it's becoming more and more, I think, made aware of by people. And I've actually written an article that should be coming out next week with Harness magazine, which I'll put on my Twitter, about postnatal depression. But yeah, so perinatal psychiatry, I mean, what it means is obviously a woman through pregnancy and we're having mental health, basically. So we have different units, and not the whole country doesn't have them. They're in certain locations. So the one I've worked in is in London, in West London, and there's a mother and baby unit, and there's a few potted around here and there, but it's such a small subspecialty at the moment that needs more sort of light shed on it. So that has a unit in which women who have just had a baby and they're suffering a relapse in their mental health or newly diagnosed in their mental health and need support as well, and they can care for their child there. So there are lots of issues, and I think in pregnancy in general, I mean, it's such a traumatic sort of event for a woman's body to go through anyway, regardless if you have health problems or mental health. I mean, your body goes through a lot. Obviously, the shape, the size, the blood volume, the way you digest food.
Got all those hormones,
hormones
everything
flying around. Yeah, I mean, it's horrendous. I mean, it's incredible how women even had children in the days before any healthcare. It's absolutely extraordinary.
It's a little scary.
It's life-threatening. Yeah, it's absolutely it's so terrifying. So, I mean, it puts a lot of stress on your body. And because of that stress, you sometimes can be increased risk of getting mental health. So let's talk about this. So pregnancy in general is linked to about 2 to 3% of spontaneous major malformation with the fetus, and drugs, so medication, can account for about 5 in 100 of those malformations. So even without drugs, medication, you can still naturally have a spontaneous, issue with your pregnancy and have, miscarriage, etc. So pregnancy accounts for an increased risk of suicide and mental health in women, especially in the first 3 months of postpartum. What postpartum means is after pregnancy. So you've had the child. So you might hear me saying these terms. So perinatal, peri is during pregnancy, post is after, and prenatal is obviously before pregnancy. And one thing that we need to remember is about 80% are mood disorders related with mental health. So quite a big number with mood disorders.
Yeah.
10% depression there's a 10% risk of depression in pregnancy, and more so in developing countries. Reasons why, I mean, there's lots of different theories going around. I'm not sure. And the relapse of depression, if you've had a past history, is 50% when you're pregnant. So it's quite a lot.
Wow,
so 1 in 2 women Yeah, so I mean, that's extraordinary. If you say for instance, I have had a history of depression and then I'm now pregnant, I could go in a relapse of depression in
Wow.
50%. So it's huge. So it's something to be taken really seriously. And there's a lot of stigma to it, actually. So I actually know somebody who went through postnatal depression and still hasn't sought help, and it's been years and years, and they're really suffering. And unfortunately, it's not only you that suffers, it's your children and your family around you, and everyone goes through it with you.
Yeah.
So it's quite serious, actually. And I hope more people come forward, and hopefully they will with time. Going back to the facts, so 25% risk of postpartum psychosis in general public, and 50% in bipolar disorder, and up to 90% if you've had a history of postpartum psychosis. So
wow.
Yeah, quite big.
Wow.
Yeah, it's a lot. So people don't realise that. So I think it will go in when Diane talks about her book, and because she talks about, postpartum bipolar. So, yeah. I mean, 50% of those with bipolar disorder can go and get postpartum psychosis and relapse. And just explaining that a bit further. So if you've had a past history of having postpartum psychosis in the past, again, 90% happening again. So wow. Huge numbers. And sort of why these things happen, people are not 100% certain. They think, it's hormone related, physiological, and also just the stress and the trauma of actually having a child. I mean, it's a traumatic event, essentially. And childbirth, abortion, and menstruation are all triggers, actually, of bipolar episodes. So
that's interesting.
All these kind of things. Yeah, I think it's just the stress of sort of these events that impact the mind and the body, which can trigger it. And most relapses are depressive. So I think some people always think it's a manic episode, but most are depressive, actually. And sort of the outcomes for the mums going through these issues is they can have an increased risk of suicide, having substance misuse problems, alcohol related issues, having an unhealthy lifestyle, not taking care of themselves, not sleeping, being quite impulsive in their acts, and missing perinatal appointments with their GP, obstetrician, even with their psychiatric team as well, because they're just not looking after themselves, unfortunately. And the outcome for the actual fetus is they might have a low birth weight, might have a small head circumference, preterm birth. There might be issues with attachment, behavioural, cognitive problems, neurological problems as well. Obviously, we have to think about intrauterine death. So unfortunately, a stillbirth, abnormalities in the child physically as well. And if you have a mother that's been abusing, drugs or alcohol, you have to think about things like fetal alcohol syndrome. And obviously with the child, if they're being neglected, if a mother's, not well, quite severely mentally health unwell, then there might be infanticide, so killing of the child in the first year. So it's something we need to remember. And in another podcast, we talk about that. So the risk of a baby dying is most likely in the first 24 hours, actually, from the mum. So it's quite a high risk time, pregnancy in general, and also after birth. Now, treatment generally as a whole, really, with anything with perinatal psychiatry is really individual basis. So it's really looking at the woman, her lifestyle, sort of her history, looking at her developmental features and what's going on in her situation, and tailoring your treatment. So it's not a clear bang, I'm going to give you this treatment. You've really got to tailor it, because you also have to remember she's pregnant, she might be breastfeeding, she might have children at home, and again, it's individual, and she'll be checked on really regularly, and more so than a woman in her normal pregnancy care, but she'll have a bit more attention, obviously. And we have to think about weeks 6 and 10 in pregnancy is the most vulnerable. So when I say vulnerable, that's the most risk of any teratogenic effects on the fetus if you're taking medication. So the first trimester is very
sensitive, kind of, yeah.
Yeah, very high risk. And even like women who don't have any health problems, they don't normally tell people after the 12 weeks anyway, because it is quite high risk anyway. But even more so if you are on medication, obviously. And we have to remember, which I said earlier, you might need higher doses of your medication because the blood volume in a pregnant woman expands in pregnancy. So you have to always be tailoring her treatment plan or her management plan as well, and keep an extra close eye on her. So schizophrenia, so the risk is very high if it's not treated, actually. So if you've got schizophrenia and you're not taking your medications, then you're at high risk of relapsing.
I guess for some women, they may be concerned as well if they found out they're pregnant and they're taking these types of medications. Do you also find that at all?
Yeah, so perfect. I'm glad you asked that. I was going to talk about that. So yeah, so I mean, obviously, if you're planning on having a baby, what I would suggest is you make the earliest appointment to talk to your GP or your psychiatric team, and you sit down with them and look at the medications you're taking. You look at your history about when was the last time you had a relapse and what you're doing otherwise. Like, are you doing psychology work as well to help assist you? And some medication is relatively safe. And I'm going to talk about some medications you can take in pregnancy in a bit. So just carrying on with your question here. So you meet, no, it's good you ask. I think, people want to know about this. So you meet with your psychiatric team and you look at what's going on in your life. If you're not in a relapse, acutely unwell state, you're maintained in the way, and your medication. And if it's possible, they will try their best to wean you off if it's safe. Now, doctors will not wean you off if you're at very high risk, because at the end of the day, mum comes first and baby second when you're pregnant. Okay, so fetus comes second. And at the end of the day, it's the mum that you need to be looking after. And the same with medical doctors. So if you get a pregnant woman that has had a cardiac arrest, and you are going to save the mum rather than the fetus, because mum comes first. Okay, if you can. Obviously, it gets into the law after 24 weeks of, the fetus has their own right to life, etc. But that's a different issue. So you'll meet with your team, and if it's possible, you will adjust your medication, change your medication, reduce the dose, or adjust it, or take them off, or wean it if you can. But if it's, so like with schizophrenia, if you're kind of quite acutely unwell anyway, it's really recommended actually you maintain your medication for schizophrenia, but you can change your medication. So olanzapine is widely used in schizophrenia because it's relatively safe actually compared to other antipsychotics. So you do get pregnant women that continue with, say, olanzapine antipsychotic for schizophrenia, and baby's absolutely fine because it's relatively safe. But again, it depends on what mental health issues you have. If you're on a mood stabilizer, if you're going through bipolar or depression, anxiety, etc. There are different medications you can use in pregnancy that will keep you and the baby safe. But again, it's tailored, basically.
That's good to know for those out there. Exactly. Yeah. That is good to know. So really check out with your GP and your psychiatric team to find out what's the best thing.
Yeah. And also I want to say, obviously, some women, you don't plan these things, you just do fall pregnant. No. And for those women, I would say, again, make the earliest appointment, because again, you need more scans and more appointments than other women just to check on the baby and do ultrasounds and assessments and just check on eye on you as well to make sure everything's okay and any support you need as well.
Again, that's good to know, because that gives you kind of that reassurance that the health team is looking out for you and your unborn child. That's good.
And also, I just want to make a quick point. Mothers with mental health make excellent mothers as well. So I think there's a concern that, if you have schizophrenia or something, you're not going to make a great mum. That's absolutely not the case. That, there are terrific mothers out there. And again, say like stigma, labeling someone with mental health, that's not the case. So any mums or mums to be with mental health, I'm sure you're going to make a fantastic mum. Obviously get the support and make sure you're following up your appointments and do everything that you need to do, but there's no reason why you can't have a happy, healthy family life.
Again, another good thing. I mean, I think we've probably recently talked about my own concerns associated with mental health and potentially becoming a mum and being worried. And I just think it's something that if you are suffering with a mental health condition, you are going to be concerned about.
It's natural.
And it's natural to be concerned. Yeah.
I mean, I know lots of women who don't mental health and they're absolutely petrified. I mean, it's a terrifying thought to be a parent. You want to be, the best parent you can.
Exactly. Yeah. You want to.
Even men, you want to be the best one you can. And I'm going to talk about men actually with postpartum depression later, actually. Excellent. Because it's not just women that suffer during this time, it's men as well. But I'll talk about that later. So depression in pregnancy. So you try in the second and third trimester to treat them, and you try and avoid medication in the first trimester just because of, it's a vulnerable time and you want to avoid any sort of developmental issues with the baby. So, but treatment if needed. I mean, obviously if you have to treat them, you need medication, then obviously you will. But if you can avoid, you will try looking into CBT first and looking at the supportive measures around you, if possible, before medication. And if you are able to, and that all doesn't work, then we look at medication in the second or third trimester. And here you wouldn't take paroxetine. So anyone taking paroxetine, you would avoid taking that, and please see your psychiatrist about that, because paroxetine has a high risk of something called VSD, so it's ventral septal defect in the fetus, and you can get neonatal withdrawals as well. But fluoxetine with an F, that's relatively safe actually in pregnancy. So that's okay if you're on it really, but obviously still make sure you're talking to your psychiatrist.
It's always best to double check, isn't it?
It's always best to double check, yeah, but please don't take paroxetine with a P. Now, bipolar affective disorder. So here you should continue your medication throughout pregnancy, regardless of the first trimester rule, because the risk, as we said, is quite high going into relapse. So 50%.
Yeah, you said it was incredible.
And, yeah, so it's very high. So it's safer to take it throughout, and only stop your medications if it's absolutely necessary, and that will be, please, with your team looking after you, because your risk of relapse is very high, so we need to be keeping an eye on you. And here, if you're on valproate or a medication called carbamazepine, you will tend to not give this in pregnancy and change the medication, or you can give folic acid before becoming pregnant if you're able to. Obviously you can't help it. And you would also give something called vitamin K after delivery. And the reason that you give these sort of vitamins is to help with any neural defects like spina bifida, because you'll increase chance of having neural defects on valproate and carbamazepine essentially, and folic acid and vitamin K helps prevent that basically. And if you're on lithium's very dangerous in pregnancy. 1 in 10 you could have a chance of a malformation in pregnancy, and it's something that we look for called Epstein's anomaly. So it's very, very dangerous in pregnancy. So if you are planning, again, I'll keep saying this, but if you're on lithium and you're planning on having a family, please talk to your doctor, because we'll need to see if we can change that medication, because it's quite dangerous for the baby. Also, lamotrigine, if you're on that medication, again, not great, because you can get cleft palate in the baby as well. So, if you're on medication, planning a baby, just get things ready in advance. I say just get the help you need. Also, some people are on benzodiazepines, and some people do get addicted to that. In the baby, you can get respiratory depression, hypotonia, which we call floppy baby syndrome. So again, we want to be avoiding this for the fetus. ECT. So some people do have ECT, and I think Diane mentions that at some point, doesn't she? Yeah. So, there's not a great deal of studies in ECT in pregnancy, but from what I've seen, there's not many issues or complications during pregnancy, actually. And some people are really worried that they'll go into like premature labour, but that's really unlikely, because during your ECT, your seizures, your uterine smooth muscle doesn't routinely contract during the seizure, so it's very unlikely that would happen. But you do need to just be aware that if you have prolonged gastric emptying, that can happen in pregnancy. You could be at risk of gastric regurgitation and aspiration because of the vomit essentially, and aspiration pneumonia because of that. So again, this will be looked at by your psychiatric team as well to make sure it's safe, but relatively, there haven't been much reported issues with that. Just talking, because Diane mentions it, how did she find with the ECT?
She said that she was very happy with her experience with ECT. So she did bilateral on her first bout of depression, and then because it became worse, she then went for unilateral ECT. She said that she woke up, she didn't necessarily have too many side effects, and it did help.
Brilliant.
So she gave a big thumbs up. And so unlike obviously when you see One Flew Over the Cuckoo's Nest, and you look at that and he's kind of being given ECT as a punishment, it's definitely, it seems that she had a positive experience.
Yeah. That's really interesting, because I haven't met one patient that doesn't like ECT. No.
Wow.
And this is the thing, because we have even because I train, I do ECT. Yeah. So when I initially was going to it, I exactly was thinking of that film, and I really thought it was going to be quite barbaric, the whole experience, but it really isn't. And the patients that we have keep wanting it, actually. And not many facilities do it, so they see it as a privilege, and they have had a terrific. I haven't met one person that's had a bad experience, so I'd really love to hear if anyone has, because I've never met one. Yeah, and they're very comfortable, and they see a difference.
Yeah, exactly. If there's something that is
life saving,
if it's giving you that kind of relief, why wouldn't you do it? I would, I would certainly try anything and everything. And because she is medication resistant, and she said it was a lifesaver.
It's life-saving.
Yeah.
Yeah, it is definitely. And I mean, there's a strict criteria who has ECT, because it is just that life-saving last resort, essentially, in certain sort of syndromes. And the effect is absolutely phenomenal. Like, it's absolutely incredible. And the patients, they do so well on it, and they get their life back. So, I mean, great to hear if anybody has that experience as well.
Yeah, certainly.
Right, so I want to talk about breastfeeding. We might as well talk about when the baby comes and that you've gone through that process.
You pop him out.
So breastfeeding, you pop them out and now you've got to feed them. So obviously it's your choice whether you want to breastfeed or not. So most women, I mean, I say that loosely, but I feel like most women do want to breastfeed, actually. They want to have that connection with their baby, and it is better for the baby, actually, and their health. But let's talk about breastfeeding with medication.
Yeah.
So what we use as psychiatrists, we use a Maudsley guidelines, which helps us a lot with medication and what to give, etc. So you can take certain medications and breastfeeding, and there's absolutely no issue. But just as in pregnancy, you have to avoid certain medications or be aware. It's the same here. So the ones you can take, because I thought this might be a bit easier, because there's lots you can't take.
You're like, let's go for the smaller list.
Let's go for the positives. Right? Yeah. So antidepressants, it's relatively fine to use sertraline and paroxetine.
Sorry.
So in like pregnancy, yay!
I'm like, yay!
Medication. So in pregnancy, I said you can't use paroxetine, whereas in breastfeeding you can.
Okay.
So, and the reason for this is what we're looking at is how much medication goes into the milk and basically is transported into the milk. So that's what we're looking at. That's relatively very small. So it's quite safe.
So in comparison to it going between mum and baby through the blood system.
Yeah.
Okay,
exactly.
Cool.
And in pregnancy, when we said avoid certain medications, it's because the placenta exposure from going into mum's bloodstream through the placenta into baby, basically. So if you're taking antipsychotics, relatively good are sulpride and olanzapine again. If you're on mood stabilizers, essentially avoid mood stabilizers if you can, but if you can't, valproate's pretty much your best bet, basically. And if you're on sedatives, so some people take like sleeping tablets or to help with anxiety, what we would recommend in anxiety if you're breastfeeding is lorazepam or zolpidem for sleeping. Okay. But going back to lithium, this is contraindicated. So you would need to have a very serious discussion with your obstetric team and psychiatric team, because 50% is excreted in breast milk.
Wow.
So, I mean, another option you can have, because it is quite high, isn't it? Like, you could not breastfeed your child, but as in if you want to, there are options. But
it's difficult, isn't it?
Kind of, I mean, it's a judgment call and get all the information you need.
Well,
but
particularly if you,
I mean, there are.
Yeah, if you need that, if, for example, you've come off of lithium during the pregnancy and it hasn't necessarily gone so well for you, you may unfortunately need to go back on, regardless of wanting to breastfeed or not. And I think that's a shame for women.
It is a shame because, it's a shame you have to choose breastfeed or not, because I think it's such a personal connection you have with your child, you know, to feed them and have that bond and that skin to skin contact. I mean, I'm sure it means so much to women in their own ways. But, you know, I think also the good thing though with breastfeeding is you can choose not to though, if your health comes first.
There is an alternative. It's not like your baby is going to suffer hugely if you choose to use formula.
Exactly.
I mean, I've been told that I wouldn't necessarily be allowed to breastfeed because I'd need to go back onto my MS medication straight away.
Right.
So, and again, you go, well, I'd rather be healthy for the baby.
Yeah.
And
absolutely. You need to be a healthy mum for your healthy baby. Exactly. You need to look after yourself, because how can you look after your child? I think that comes first. And I think that's what we don't look after ourselves that much. Like,
no, exactly. Everyone else is more important.
Yeah, you've got to look after yourself.
I think mums are worse.
Yeah.
Really, in some ways.
Yeah. And I think that's another thing. Everyone's promoting sort of self-care. And I think that's so important, because I think people feel guilty if you take your time out to look after yourself. And really, you shouldn't feel guilty, because you've got to be healthy.
Exactly.
And if that means you've got to do certain things, you've got to do them, and you shouldn't feel bad about it.
Exactly. But I don't know, maybe that's just something that in some ways we're all socialised to feel, is this, all this guilt and shame associated with, looking after ourselves and doing things for us. Yeah. It's one of those things I struggle with.
Yeah. No, I do. And I used to be somebody, and I still am slightly, but I do struggle with saying no quite a lot. And that's the big, do you struggle with that as well?
Yes. Oh, yes.
Yeah.
And you're like, why did I say
guilty,
yes?
Don't you? Yeah. Because you end up just tormenting yourself. It's just, so I met this friend. I am friends with this guy, and he's a psychiatrist as well, actually. Really funny. We met in med school and met him 10 years later, and we met in psychiatry. It's such an odd world. It's such a small world. But no, and he kind of taught me to say no, because he's somebody really well liked by people, but he has absolutely no problem sort of saying, sorry, I don't want to come to this. I don't want to come to your whatever it is, you know?
You're just about to reveal the secret. Because I'm now But
the thing is, the way to do it, and I was watching him, and the way to do it and still be liked by people is be yourself, be your nice, happy self, but just say, that sounds really great, but it's really not for me, but don't take that personally, it's just not for me. And say something like that, and people still enjoy his company. Like, when he's turned me down a few times when I've invited him to a few socials, but it doesn't hurt me at all, because I know that's just like saying, can you change from the colour blue to red? It's just not possible. That's just him, and he's still well liked. And I think that's the fear, is that if we say no, that we're hurting people, they won't like us.
They're going to abandon me if I say no.
Exactly. And that's not the case.
No, exactly.
Yeah. And I think you've just got to be nice and confident when saying it. So now I've become much better, actually, and I'm much happier because of it, because I'm not drowning in trying to make everyone else happy instead of myself. So now I kind of say with a clear conscience, really sorry, but I just... sometimes I say, I really can't actually at that time. I'm really sorry, but I hope you have a great time. And I do sometimes ponder about it. I'm like, I feel a bit bad. And I think, no, it's fine. Like, I wouldn't expect them to do something they don't want to do.
Exactly.
So it's just learning and practicing, really. And I think, we've just got to practice, say no.
Exactly. Just no.
Yeah. And I've noticed at work, because initially I remember the first few years when I was a doctor, I didn't know how to say no. So I really, honestly, almost killed myself to see all the patients, speak to all the relatives every day. And I just had to be like, you know what? No, I'm leaving at 11 p.m. every day. I need to get home because I'm back at 6 a.m. And it takes practice. And you feel, I have to say, as a doctor, you feel a lot of guilt, because you always feel like you could do more and speak to everyone. And, relatives obviously want to speak to you on a daily basis, but you know what? Sometimes you just cannot, and you have to do what you have to do the essentials, and anything extra, if it's, going past now 6 p.m, I'm just going to say no, and I have to be another day. And you just get more comfortable with it, whether it's, professional life or personal. And it does just take practice. So now I don't feel guilt at work, because as in I can't work myself to the ground.
Well, you can't burn yourself out.
Exactly.
Really, yeah.
And I think with, personal, I'm getting on the side note, because you do get really stressed out, I think, personally, if you trying to do things you don't want to do, and it's just really unhealthy.
Yeah. So that's part 1 of our episode on postpartum mental health. Part 2 will be released on Wednesday. If you are impatient and want to get it all now, you can head over to Patreon at patreon.com/MHBC and sign up, and you can get the full episode with some bonus material straight away. So until next time, it's okay to not be okay, and if you're not okay, talk. Thanks for listening to this episode of the Mental Health Book Club podcast. If you need additional help with your mental health, please contact the Samaritans on 116-123, which is a 24-hour helpline. And if you need additional information about mental health issues, please visit Mind at mind.org.uk. Our next book will be A Beginner's Guide to Being Mental, an A to Z from Anxiety to Zero Given by Natasha Devon, the next episode with the Secret Psychiatrist will be the second half of the discussion on postpartum mental health. If you'd like to find out more about the MHBC podcast, please visit our website, mentalhealthbookclub.com. We really hope that you enjoy this podcast, and we would like to hear what you think. Please head over to Twitter and follow us at MHBC_podcast, or head over to Facebook and follow our Facebook page, which is Mental Health Book Club. If you would like to show your support further, please share us with your family and friends, and leave us a 5-star review wherever you get your podcasts. We are now on Patreon. Please head over to patreon.com/MHBC to donate as little as $2 a month to the Mental Health Book Club podcast. As a result of your donation, you will get early access to some of our episodes, you will get specific episodes that are only for patrons, and you'll be eligible to be entered into free prize draws.